Okay. Okay, so Dr. Max Spaderna, I just want to thank you so much for taking the time to talk to us about medications for alcohol use disorder. And you are an expert in doing this with the mental health population. So we're just going to I'm going to be asking you some questions and asking you to respond, and then we'll cover the medications, we'll cover different approaches and different things that perhaps prescribers might be interested in knowing about before starting on somebody on one of these medications. So can you talk a little bit, Dr. Spaderna, about harm reduction versus abstinence as a treatment goal?
Yes, absolutely. So we once thought that abstinence was what we should be aiming for, that this was the optimal outcome. The problem was that fewer than one-third of individuals with alcohol use disorder who were in treatment actually achieved alcohol abstinence. Now, the reason for this was that most people who actually are in treatment don't necessarily want abstinence as a goal. Instead, people want to reduce their drinking as their end goal of treatment. And we now know from studies that this actually is a important outcome to have. So we know from previous work that a one shift reduction in risk drinking levels, according to the World Health Organization, is associated significantly with fewer alcohol related consequences and better mental health, and that these are actually sustained for about 1 year following treatment. Moreover, people who are heavy drinking non-responders, that the most of those actually achieve clinically meaningful reductions in heavy drinking from treatment. So there's a lot of benefit that comes from just reducing alcohol use, even if they don't achieve abstinence. This has actually led to a big shift in how we think about treatment. So in 2025, the Food and Drug Administration actually formally recognized reductions in risk drinking levels as a valid primary endpoint in alcohol clinical trials. So if you have two risk level reduction, that's now as a primary endpoint for heavy drinking, and that is actually considered now a valid outcome for trials. So providers who use these medications should consider that abstinence, while great, is not always what we're looking for, and that if we can reduce someone's alcohol use, that that's a treatment success.
That's fantastic. That's, I think, perhaps something that a lot of folks don't readily know, and that's a really helpful perspective to integrate into treatment. What are some ways and suggestions you might have on how to start a conversation with somebody about medication for problematic drinking?
Yeah, that's a good question. So whenever we have these conversations, it's important to be non-judgmental. There's so much stigma around alcohol use. It's important to establish a rapport where people feel comfortable discussing it without feeling judged. I would do that by normalizing it medically. Instead of framing it as a personal failing, I would frame it really as a medical condition, which it is. No different from how you would treat blood pressure or diabetes. We wouldn't say to someone whose hemoglobin A1C is, 10, well, we're not going to treat this because you're eating sweets. That would be a violation of the gold standard of our duties as medical providers. It's a similar thing. So I would frame it and think about it in that way. And I would really avoid using stigmatizing language. Again, you want people to feel comfortable and you want to establish rapport to optimize the best outcomes for treatment. It's important to also see where people are at. Again, as we mentioned before, people have different goals for treatment. There are people who want to abstain. There are people who would rather cut back on their alcohol use. Understanding that will help you know where people are at, how you can help them, and really develop a treatment relationship. I would give people the education because many people don't know about that there are medications out there that are effective for alcohol use disorder. giving the education, explaining the effectiveness will help people feel confident that you will benefit it and will encourage them to take the medication. And like with any treatment, you want to tailor it for the patient. The good news is we have many different medication options, which we'll discuss depending on your patient and what you discuss and what your patient's goals are. You can really tailor the treatment accordingly and find the right medication that works for your patient.
That's wonderful. Yeah. Yeah, because the stigmatizing language is something that sometimes so many people experience when it comes to these kinds of difficulties. So we're going to move into the medications that are FDA approved for alcohol use disorder. And for those listening, I'm using that term, but these medications can be beneficial to people that don't necessarily have that diagnosis, but that are having problematic drinking. They don't have to have an alcohol use disorder diagnosis. So the first one we're going to talk about is naltrexone. So could you say a little bit about naltrexone, Dr. Spaderna?
Absolutely. So naltrexone works by blocking the mu opioid receptors involved in the brain reward pathway. So it helps prevent the rewarding features of alcohol use. Now, there's really strong evidence for naltrexone's use in reducing alcohol cravings and heavy drinking. It does promote abstinence, but the evidence suggests that it's less effective in doing this than acamprosate. Now, a good way to look at its effectiveness is the number needed to treat. Now, what this is it's a number that tells us how many patients must receive the medication to prevent one additional negative outcome from happening. So if we're looking at, let's say, abstinence or, return to any drinking or heavy drinking, that we look at seeing how many patients need to be treated with this medication to prevent that bad outcome from occurring. A way to think about it is if you have a lower number needed to treat, that means that the medication is more effective in preventing those bad outcomes from happening. So when we look at large meta-analyses, looking at these medications, what we find is that the number needed to treat to prevent any return to heavy drinking with naltrexone, and heavy drinking we defined as more than 4 drinks a day for women or more than 5 drinks a day for men, is between 9 and 11. And to prevent any return to drinking, the number needed to treat with naltrexone is 18. Now, we're throwing out these numbers. You may be wondering, well, what does that mean? That doesn't sound maybe so promising. So let me actually shift it a bit. So the number needed to treat with antihypertensive to prevent a cardiovascular event in high-risk patients. So these are people who have a high risk of developing cardiovascular disease, about over 21% over a 5-year period. The number needed to treat for those antihypertensives is 26. So naltrexone is better to has a lower number needed to treat to prevent any return to drinking or heavy drinking than preventing a cardiovascular event in high-risk patients with at high risk of cardiovascular disease. And this is important because so much morbidity and mortality is associated with alcohol use. So to see these numbers needed to treat in this range shows that these are very effective medications. Now, when we prescribe these medications, people can take it in different ways. So with naltrexone, people can take it every day, but people can also take it as needed. So I have had patients who will take it, let's say if they're going to be in a social situation, they're going to drink, they'll take it so that if normally they would maybe have 6 drinks, they'll go down to 3 drinks. Or if they're having cravings in certain situations and they don't want to drink. So you can take it as needed. So who are like the patients, Caroline, who are really good for naltrexone? I think about patients who are interested in reducing their alcohol use, if you're interested in abstaining, and patients who are not using opioids. And that's important because it's an opioid blocker. The other thing is that there's an intramuscular version, Vivitrol, and this is really good for people who have difficulty taking medications every day. But I would caution, you want to make sure to avoid this in people with opioid use disorder or are using opioid use opioids illicitly or through a prescription because it can cause opioid withdrawal, and also with people who have acute liver failure or have progressed liver disease, though mild transaminitis happens with alcohol use, and a medication that reduces alcohol use, like naltrexone, is the best thing to prevent liver problems. So not complete contraindication. So that's naltrexone, usually like my
Mm-hmm.
first line.
Mm-hmm.
Now, moving on to Acamprosate, another great medication. Its mechanism of action is that it's a glutamate or MDA receptor antagonist, and also the positive modulator of GABA receptors. So the way I think about it is that with heavy alcohol use, what happens is that you have the excitatory side of your brain with glutamate, the inhibitory side with GABA, that gets all out of sync and there's a disequilibrium. I think Acamprosate helps to restore that equilibrium, decrease the cravings, and alleviate the withdrawal symptoms like anxiety and this insomnia associated with alcohol use. Now, it's meta-analyses, the number needed to treat to prevent any return to drinking is between 9 and 12, so pretty good. Compared to placebo, however, it has not been shown to reduce a return to heavy drinking. So who is this a good option for? So for patients who have achieved abstinence and they want to stay off of alcohol, this is a great way to maintain it. It's also good for patients who, for whatever reason, can't take naltrexone, whether that be because they're on opioids or they have really pronounced liver issues. It's renally excreted, so that's nice, especially for people with liver problems, but you do want to use cautiously in people who have renal impairment, and you might want to consider adjusting the doses for people who have renal problems. So that's Acamprosate.
Mm-hmm.
Disulfiram is the last FDA approved medication for alcohol use disorder. So the mechanism of action for this is that you have alcohol, it's broken down in the body to acetaldehyde. And this causes a lot of the aversive reaction that happens with alcohol. The acetaldehyde is broken down to acetate, which is harmless, by the enzyme aldehyde dehydrogenase. So what disulfiram does is it blocks aldehyde dehydrogenase. So you get a buildup of acetaldehyde, which creates this very uncomfortable aversive reaction. So the idea is you take disulfiram, you drink alcohol, you get this really negative reaction, and you say, I'm not doing that again. So the evidence does not support its efficacy for any return to any drinking. And the reason is that the medication works if you take it. If you want to go drinking, you're not necessarily going to take it. So who's this really good for? So it's good for a really highly motivated patient who has excellent adherence and has a certain health literacy where they can take this medication and know I can't take alcohol with it, or that there needs to be guardrails in place for me to do that, and they're able to adhere to that. So people who you're considering this for, you have to really make sure that they're aware of this disulfiram ethanol reaction, which is very uncomfortable, that they have to have abstained from alcohol use about 12 hours before their first dose. You have to be careful because other places where you might unexpectedly get alcohol, whether it be like cooking wine, mouthwash, hand sanitizer, that could be a concern. Again, that's probably overblown, but something you want to just let people know about.
Mm-hmm.
The other thing, so you want to avoid in people with severe cardiac disease. It's not a medication I would prescribe for someone who concerned about with severe cognitive impairments because of the importance of adherence or psychosis, which get worse. In terms of pregnancy, it's a category C. So it means that there's no evidence to show that it does cause adverse outcomes in fetuses and newborns. But the concern is that if you take disulfiram, a pregnant woman experiences the aversive reaction to it, that this can cause a lot of physical distress that could be damaging to the developing fetus and to the newborn. So that's why it's usually recommended not to use it. And for someone who is at severe hepatic impairment, this would not be a good one because it can increase the risk of hepatotoxicity, especially within the first 2 to 12 weeks of treatment. So those are all of the FDA approved medications.
Great. That's wonderful. That's very helpful information. And also just listening to you talk about some of those medications, it really is very much in line with the whole way of thinking of reducing when abstinence isn't necessarily the goal, but that these medications kind of facilitate the new way of thinking about benefits from reducing drinking.
Yeah, absolutely. So,
so there are some, I'm sorry, go ahead.
I was just saying, I mean, you're absolutely right. I just want to emphasize just the flexibility that these medications offer to tailor the treatment.
Yeah, that's fantastic. So there are some non-FDA approved medications that sometimes can be useful in treating problematic drinking. The first one being Topiramate. Can you say a little more about that?
Yeah, so Topiramate is an anticonvulsant. It works by blocking the voltage-gated sodium channels, and this increases the inhibitory GABA receptor activity and antagonizes the excitatory glutamate receptors. And it's thought by doing so, this inhibits the activation of the brain's reward pathway that gets activated with alcohol use. Now, while it's not approved by the Food and Drug Administration for alcohol use disorder, its use is supported by the American Psychiatric Association. So there's evidence to show that Topiramate reduces heavy drinking or any drinking day compared with placebo. It's really good for patients who you couldn't use some of the other medications. So like if someone's using opioids, either through prescription or illicitly, this is a good medication. And often this is a medication I'll use for patients who I treat who are using opioids or on medication for opioid use disorder. You can use this without worrying about someone going into opioid withdrawal. So it's a really good medication for that. Now, it can increase the risk of nephrolithiasis, kidney stones, so you want to be cautious using it in people with a history of that. It can also rarely cause acute angle closure glaucoma. So if someone has narrow angle glaucoma, I would be cautious using it in that population. And there is a risk that it can cause non-anion gap metabolic acidosis. So you want to be cautiously using this in someone with severe renal disease or respiratory diseases or on medications that could promote or worsen acidosis. Topiramate is category D, so there is a concern for oral cleft risk, so it's recommended to avoid this in pregnancy. One other thing to be aware of is that with Topiramate, you can get like a brain fog. People have word finding difficulty. So that's something just to let people know about. So I would always, with all these medications, but with Topiramate, start at lowest dose, the most effective dose, and just cautiously increase.
Great. And then the final medication that is not FDA approved, but has benefit for folks with alcohol use disorder is Gabapentin.
Yeah, so Gabapentin, its mechanism of action, it blocks the voltage-dependent calcium channels, thereby preventing glutamate's excitatory effects. It also boosts GABA-A synthesis, which increases the inhibitory tone lost with alcohol use. So actually, Gabapentin is used for mild to moderate alcohol withdrawal. I've actually used it before pretty effectively. Its strongest evidence has been shown to reduce a return to heavy drinking. That's the best evidence for it. So who are the patients who could benefit from Gabapentin? So patients with co-occurring anxiety, because it is used off-label for people with anxiety or anxiety disorders. People who have like protracted alcohol withdrawal symptoms, it can be helpful for. And because it's renally excreted, it's good for people who you're concerned for hepatotoxicity. Now, few things to keep in mind. There is abuse potential with this. So if this is a concern for the patient or if there are other red flags, this is something just to be aware of. You want to also monitor if people are on other CNS or respiratory depressants because it can interact with that, especially if someone is using opioids or benzodiazepines. And again, because it's renally excreted, you want to just use this cautiously in people who have renal impairment.
That's great. Thank you for going through all of the medications, both the FDA approved and the ones that are not approved, but can benefit patients with alcohol use disorder. What would be your guidance for how to start somebody on starting AUD treatment? What would be your best advice for providers?
Yes, so I think it's always important to clarify what is the patient's goal. If someone is looking for abstinence as their goal or for reducing drinking, or if they want to make sure that, let's say, they're in a situation where they are going to drink alcohol, that they drink fewer alcoholic drinks, understanding that is important because you know which treatments would be best for your patient and you can tailor it. And in so doing, the patient is more likely to trust you and take the medication. I'd also screen for the contraindication. So again, if someone is using opioids or have hepatic or renal issues, if they're pregnant or interested in getting pregnant, they have a cardiac history, these are all things that I would keep in mind and that would determine which medication would be good or not good for the patient. So as a start, it's good to get baseline laboratory values, so like a comprehensive metabolic panel to look at electrolytes, getting liver function tests to see if there are liver issues. You might want to get a pregnancy test if you're thinking about starting Topiramate or Disulfiram. And you might want to get a urine drug screen just to rule out if people are using opioids. Again, you might not always be able to get that, but at least screen for opioid use. Because if someone takes naltrexone and they go into withdrawal, then they're never going to touch that again. So when we start the medications, just typical strategy. So for naltrexone, you can start either at 50 milligrams a day, or if you're worried about side effects, start at 25 milligrams to reduce the incidence of side effects. And, after a day or a few days, you can increase to 50 milligrams the next day. I have gone higher than 50 to 100 milligrams before, but, it really depends on the patient. The Vivitrol, which is the monthly formulation of naltrexone, again, is a great option for people who have difficulty taking a medication every day, and that's typically 380 milligrams every 4 weeks. So for that, I do look for liver functions at baseline. The hepatotoxicity risks really occurred at higher doses of naltrexone, so there's less concern for that. And again, if someone is drinking less alcohol, that's the best thing for someone's liver. But the opioids is something you really want to make sure of that they're not using. Now, the Acamprosate, you take it 3 times a day. It's 333 milligram tablets. I would get a renal function at baseline to see if you need to adjust it. For Disulfiram, the usual dose is 250 milligrams. That can range between 125 to 500 milligrams. Education is really key. So explain the reaction that can happen if someone's taking Disulfiram and drinking alcohol, that they need to be off of the alcohol for about 12 hours before their first dose, just to be careful not to come in contact with anything that might surreptitiously have alcohol in it. I'd get baseline liver function tests, and then I'd repeat in 2 weeks and consider repeating every 2 weeks for the first 1 to 2 months. And that's because while it's very rare to have hepatotoxicity, it can be serious, and it's more likely to happen in the first 1 to 2 months of treatment. For the Topiramate, I would start low at 25 milligrams. I would divide the dose. Now, again, people respond to different doses, but you can go up to as high as 200 to 300 milligrams a day, again, in divided doses. You do this to minimize the cognitive side effects. I would recommend getting kidney function and especially for someone with a history of nephrolithiasis, you might want to get a bicarbonate just to make sure that you reduce the chance of metabolic acidosis. Gabapentin, the typical dosage is between 900 and 800 milligram daily in 3 divided doses. And I would just check renal function if you need to have renal dosing. We talked about the medications, Caroline. These are important, but psychosocial treatment is also a very helpful adjunct with the medications. So cognitive behavioral therapy for alcohol use disorder, motivational enhancement to try to encourage people to explore their ambivalence, to consider whether they are ready or see what their stage of recovery is and willingness to cut back. And also groups like AA, Smart Recovery, that support network is really helpful. That's how I would approach it. Again, tailored treatment. There are a lot of options out there, so see what works for your patient and where they're at.
Yeah, sounds to me like you really approach it from the standpoint of collaboration between the patient, the therapists, other providers that are working with the patient, and really kind of helping the patient decide on goals and kind of really tailoring the treatment that is going to work for that particular patient, and then continuing to engage and discuss and reassess treatment goals and so forth over time about how to best address their issues. So any other final thoughts you'd like to share, or do you feel like you covered most everything? I think you covered a lot.
Yeah, no, I did. And I would just like to leave with encouragement to really use these medications. These work, they're effective. And to really just have a mind shift that even if you don't achieve abstinence, reducing alcohol use is so crucial. It's crucial for reducing morbidity, mortality, and really working with the patient. And if you can reduce use, you can get people in a better spot. So there are a lot of options out there. Use them. They work.
That's great. Thank you so much, Dr. Spaderna.
My pleasure.
Sure.